Hello class, my name is Natalie Chaser and I will be talking to you today about cardiomyopathy.
Hi Natalie. Regarding dilated cardiomyopathy, according to American Heart Association, dilated cardiomyopathy is the most common type, occurring mostly in adults 20 to 60. Men are more likely than women to get it. It affects the heart's ventricles and atria, the lower and upper chambers of the heart, respectively. Frequently, the disease starts in the left ventricle, the heart's main pumping chamber. The heart muscle begins to dilate, meaning it stretches and becomes thinner. Consequently, the inside of the chamber enlarges. The problem often spreads to the right ventricle and then to the right atria, and then to the atria. As the heart chambers dilate, the heart muscle doesn't contract normally and cannot pump blood very well. So as the heart becomes weaker, heart failure can occur. Dilated cardiomyopathy can also lead to heart valve problems, arrhythmias, and blood clots in the heart. Often, cause of dilated myopathy isn't known, but it seems like up to one-third of the people of those who have it inherited from their parents. And there are also certain conditions and substances that can cause dilated cardiomyopathy, such as coronary heart disease, heart attack, high blood pressure, diabetes, thyroid disease, viral hepatitis, and HIV. So it seems like infections, especially viral infections that inflame the heart, can also cause it. Alcohol, especially if you have a poor diet, can also a cause of it. Complications during the last month of pregnancy or within 5 months of birth can cause dilated cardiomyopathy as well. And certain drugs such as cocaine and amphetamines and other medicine used to treat cancer, such as doxorubicin and daunorubicin, can also cause dilated cardiomyopathy.
Hi Florence, I found what you talked about dilated cardiomyopathy very interesting, from the pathophysiology of the disease to the risk factors and causes of cardiomyopathy in the population. As with the case study of the young male that died suddenly, dilated cardiomyopathy from a research article in JAMA stated that dilated cardiomyopathy can also be a slight risk factor for sudden cardiac death, as like with the case study, and that a treatment to help prevent sudden cardiac death with people with dilated cardiomyopathy would be ICD, just as with patients with hypertrophic cardiomyopathy that have a risk factor for sudden cardiac death. The case study I chose was about cardiomyopathy. The case study states, the Dallas County Medical Examiner's Office calls to inform you that they are investigating the sudden death of one of your patients. The patient in question was a 23-year-old male recently evaluated in your office after an episode of syncope that occurred shortly after a funeral for a 21-year-old cousin who had also died suddenly. Your patient's episode of syncope was associated with transient mild dyspnea on exertion and palpitations. There was no associated chest pain. The patient denied prior medical illness. He had never been told he had a heart murmur, and there was nothing in his history to suggest prior acute rheumatic fever. Physical examination revealed a forceful systolic heave and an apical precordial impulse displaced far to the left on the chest wall. The chest radiograph showed cardiomegaly with slight atrial enlargement. An ECG confirmed the presence of left ventricular hypertrophy. His liver enzymes were slightly elevated, but serum markers of cardiac injury, enzymes and troponins, were negative for a myocardial infarction. The patient had been referred to a cardiologist for an echocardiogram to rule out hypertrophic cardiomyopathy, valvular heart disease, or coarctation of the aorta. The medical examiner relates that the patient collapsed suddenly at work while unloading a truck. Extended attempts to revive him were unsuccessful, and he was pronounced dead at the hospital a few hours later. What is cardiomyopathy? Cardiomyopathy is the intrinsic myocardial dysfunction. It is idiopathic and can be caused by many different things like inflammatory disorders, immunological diseases, systematic metabolic disorders, muscular dystrophies, and genetic disorders of myocardial fibers. There are three different types of cardiomyopathies. There's dilation, which is a progressive cardiac dilation and contractile systolic dysfunction. And then there is hypertrophic, which is caused by the myocardial hypertrophy, defective diastolic filling, and it usually can be also caused by ventricular outflow obstruction. The third type is restrictive cardiomyopathy, which is primarily decrease in ventricular compliance, resulting in impaired ventricular filling during diastole. Study on cardiac death can be associated with the myocardial hypertrophy that is associated with cardiomyopathy. It is shown that some young people who die suddenly, including athletes, it can be and have unexplained increased cardiac mass can be related to some type of cardiomyopathy. The first article talked about in 1958 was the first studies of the hypertrophic cardiomyopathy and the more detailed report in the 1960s. Back then, this disease was a rare and unusual disease. With advanced practice and technology nowadays, treatment and management protocols and guidelines have been established to treat patients by a more comprehensive understanding of the genetics, epidemiology, natural history, risk factors, and pathophysiology pathways of the disease. This hypertrophic cardiomyopathy is a common inherited heart disease. About 1 in 500 people are affected by the disease. It is a global disease reported in over 50 countries. It affects both sexes and occurs in a variety of races and ethnicities. Most affected people are non-diagnosed or asymptomatic and only diagnosed by accidental findings in clinical evaluation or by routine screenings or when they develop signs and symptoms. The disease is an autosomal dominant disease that is caused by mutations in genes that code thick and thin contractile myofilament protein in the sarcomere. So far, there are about 11 plus mutations in genes found and over 1,500 individual mutations identified among the known genes. Genetic testing is the wave of the future to help rapidly identify hypertrophic cardiomyopathy causing mutations. However, research article states genetic testing does not influence treatment plans or identify high-risk patients who may benefit from ICD therapy due to increased risk of sudden cardiac death. Genetic testing can help with family member mutations identification. There is a new hypertrophic cardiomyopathy group in this research article that they stated that is called the genotype positive, phenotype negative due to being identified with pathogenic mutation but without evidence of the disease phenotype. Future more in-depth research needs to be done in the genetic testing field for not only be able to identify the family members at risk, but to find the genetic substrates for the other patients to help with identification, and to find more in-depth um, understanding of the structural and the metabolic issues from the mutations, and to help increase the treatment regimen within the research studies for these patients. At this time, the first option in assessing people for HCM or hypertrophic cardiomyopathy is imaging tests and ECG. And the second option after that one is needed, if needed, is the genetic testing for the family mutation. Still, in the research article, it states that still most people or most primary care or physician or cardiologists still use imaging tests like echocardiograph and CMR for the best imaging tests. Intrinsic factors like obesity may influence the primary phenotype expression of HCM. HCM is a very unique, challenging, and complex disease due to its unpredictable nature, diverse clinical presentation. More common now for HCM patients it is more common from the research found now that for HCM patients to live longer lives with no or mild signs and symptoms. Still, some are at risk for developing the complications and having premature deaths, like the sudden cardiac death. Pathways and complications of the disease are risk of sudden cardiac death, heart failure, atrial fibrillation, and end-stage cardiac disease. Now, with advanced technology, better treatment of complications of disease, mortality rates have decreased by 0.5% or down to 0.5% per year from the research. SCD or sudden cardiac death is most common in young people and occurs without warning of signs and symptoms, but not commonly is associated with and is commonly associated with rigorous activities. Risk factors or markers identified for children that the research has found is the left ventricular hypertrophy and syncope for a possible increase of sudden cardiac death. With the now technology of ICD, it has helped decrease the mortality rate of patients that have the risk factor of sudden cardiac death. The research states that 1 out of 3 young competitive athletes that die is due to hypertrophic cardiomyopathy, and it is predominantly in males. At the end of the research, it talked a little bit about the treatments and options for the for different pathways and complications of the disease, which will be more in depth in Article 2. Article 2 was basically relative to Article 1 about the genetics and epidemiology of the disease. However, this article goes more in depth about the management of hypertrophic cardiomyopathy and the pathophysiology of the disease. The pathophysiology talks about the myocyte hypertrophy and how it has 3 different pathways of obstruction, diastolic dysfunction, and arrhythmias. And these 3 different pathways cause mitral regurgitation, ischemic, decreased cardio output, increased left atrial pressure, atrial fibrillation in 15 to 20% of patients, and ventricular arrhythmias. With decreased cardiac output, ischemic, and increased left atrial pressure, it could cause exertional dyspnea and chest pain. With atrial fibrillation, it could cause a stroke. With ventricular arrhythmias, it could cause the hardening and most difficult complications, sudden cardiac death, and also syncope. The management of patients with hypertrophic cardiomyopathy is directed at controlling the signs and symptoms of heart failure, prevention of sudden cardiac death, and the treatment of atrial fibrillation, and for the screening of family members to help find the risk factors and for patients in the future. The article goes more in depth about management and treatment options for the different pathways. With heart failure with LVOT obstruction, they talked about the pharmacological therapy with beta blockers and calcium channels like varenicline and disopyramide as part of the treatment plan. They also talked about how digoxin should be avoided with patients with the obstruction, and that it could be helpful with some patients to use diuretics, but it should be cautioned with these types of patients with obstructions. The non-pharmacological treatment of outflow obstruction and hypertrophic cardiomyopathy goes into talking about the two different types of invasive treatments of surgical myectomy and alcohol septal ablation. Septal myectomy helps to decrease mortality and has a success of 90 to 95% in patients, and has a very low and may reduce risk of death in the long term, with only a 1 to 2% of AV causing AV blocks, while the new up and coming is alcohol ablation that still needs a lot of research. It still could cause up to 1 to 2% mortality. It only has a success rate of 75 to 80%, and it could cause 10 to 20% chance of AV blocks, and there's no definite evidence of increased risk for concern because of the scar, but it's still a lot of research that from the article states that a lot of research needs still to be done for this procedure. Another treatment plan that was priorly used was dual chamber pacing (DDD). However, this has been taken away from randomized research, and shown that it only should be used and considered if a patient has an existing device or has refractory symptoms of the LVOT obstruction and is not a candidate for septal reduction therapy due to the high risk with this type of procedure. Patients with heart failure without LVOT obstruction, our treatment plans for them are beta blockers and rampuril, or calcium channel blockers. Mostly beta blockers is the first line therapy, and diuretics are more used more aggressively in this setting. For patients that are with end-stage hypertrophic cardiomyopathy, they are more likely, the medical therapy and guideline for them is a heart transplant. The treatment for sudden cardiac death, or prevention for this, is ICDs. A study showed that appropriate ICD therapy is frequent with an annual rate of 5.5%, and that ICDs are effective in terminating ventricular tachycardia and ventricular fibrillation despite the very complex hypertrophic cardiomyopathy phenotypes. Risk factors that were established as risk markers for sudden cardiac death is family history of sudden death, syncope, non-sustained ventricular tachycardia, massive left ventricular hypertrophy, and abnormal blood pressure response to exercises in patients. Potential risk factors that they have found is LV apical aneurysms, LVOT obstructions, late gadolinium enhancement on the CMRs or the imaging sites, and the high-risk genotypes of certain patients. The article also proposed clinical screening strategies with screenings of family members with history and physical examination, 12-lead EKGs, and echocardiograph or CMRs. They talked about how the different age groups of like ages 12 to 21 or older how they should be screened with families members having that risk factor in place. The article also mentioned genetic testing. However, it is most useful in family screenings for patients that have the already mutation identified with the risk factors in place. Lastly, the article mentions about how there is a need for more research to help improve the care of these patients. Long-term data and research for that alcohol septal ablation done in research against the other type of treatment, the myectomy, and improvements in the association of risk factors for patients for sudden cardiac death to help identify the risk and management of these patients, to help quickly identify them to have an ICD placement to help keep decreasing the mortality rates. Also, it talked about, lastly, was the genotyping and genetic testing becoming more frequently used to help to make and more research being done to help make the process cheaper and more um, eligible and more out there for people to use, so it helps in the long term for all these people and the progression of the disease. Article 3, although this article begins almost exactly the same as the other two articles as far as years of research and type of research, it does focus more on the mutation. After extensive research, it was found that instead of 7 mutations in one gene, that has now expanded to 11 or more causative genes. These genes encode thick and thin myofilament proteins. The two most common genes that cause 70% of the hypertrophic cardiomyopathy is the beta-myosin heavy chain and the myosin-binding protein C. The other genes that include about 1 to 5% are the troponin T, troponin I, and alpha troponin myosin and alpha actin. This particular article also speaks of the legal implications, basically the confidentiality concerns. Since the year of 2008, the United States has parted a legislative protection from genetic discriminatory practice, known as the Genetic Informatics Non-Discrimination Act, GINA. This act is a federal law where no employers and healthcare providers can deny insurance, employment, or promotion to a family due to history of a genetic disease. At the end of the article, it also spoke about how researchers and healthcare providers need to be more diligent in reporting mutations to help create a standardization and less ambiguity in the hope to find a better understanding of hypertrophic cardiomyopathy in the genetics. This will hopefully, with the more increased research and communication between researchers and the reporting of hypertrophic cardiomyopathy, it will increase and achieve the confidence of the community and the full potential of the genetic information to help with making decisions and treatment plans and help with just the overall care and quality of these patients' lives that are affected by hypertrophic cardiomyopathy. Overall, the critique of the articles is the need for further research on genetic testing to, to help identify risk factors and the need for more research to improve the care in the population, to help advance technologies to improve and study treatments to help with prevention and treatment of individualized complications of the disease, and to help understand the structural and metabolic differences caused by the gene mutation, to find better treatments to target the pathways of the disease, to help to eliminate or prevent or help with longevity of life for these patients. All these articles mostly spoke about the many gene mutations that cause the hypertrophic cardiomyopathy and the genetics of the disease. After research and reading the articles, the research articles, the sudden death of the young man in the case study was due to hypertrophic cardiomyopathy due to the signs and symptoms related, the risk factors like the syncope and the left ventricular hypertrophy, and it being common for sudden cardiac death in young adults and people less than 30 years old. The research in all the articles mostly state that with the genetic mutation of having the hypertrophy, that is not uncommon for patients with hypertrophic cardiomyopathy to have sudden cardiac death in younger population and in athletes with vigorous activity. I hope you enjoy the presentation. Thank you.